This video highlights the 10 different techniques of anterior capsulotomy which can be used based on a case scenario. A successful outcome in pediatric cataract surgery is determined by an intact, well-centered, continuous curvilinear anterior capsulotomy, the tensile strength of which not only aids in further steps of cataract surgery but also in the bag implantation of the intraocular lens. The thin, elastic anterior capsule poses a challenge in children, especially in infants, which may run away to the equator and cause uncertainty of the stability of the capsular bag. The manual continuous curvilinear capsulorhexis using the microrhexis forceps is the gold standard for capsulotomy in children. After an initiation of capsulorhexis by a cystotome, the free edge of the capsulotomy flap is grasped with rhexis forceps and a centripetal tearing force is applied. The capsulotomy flap is re-grasped at the leading edge of the anterior capsule and then pulled inward. This technique has a steep learning curve and may be difficult in conditions where the morphology of anterior capsule is compromised, such as in trauma, presence of a plaque, subluxated lens, and/or associated with anterior segment pathologies. A high molecular weight ophthalmic viscoelastic device is preferred to maintain the anterior chamber, for pupillary dilatation and to flatten the anterior capsule and to keep it lax. Capsulotomy done with the aid of viscoelastic device is called Vitrectorhexis. Should there be a deep anterior chamber and variable pupillary dilatation, such as in myopic eyes, the use of continuous irrigation fluid to maintain the anterior chamber and adequate pupillary dilatation can be used during the rhexis. Hydrorhexis, that is, capsulotomy carried out while using an irrigation fluid, not only aids in maintaining the anterior chamber but also in stabilizing the globe. Coaxial illumination provides a sustained red reflex throughout the surgery, enhancing the contrast for edge, size, and the course of capsulotomy, and can be used for better visualization of the capsulorhexis in cases of partial cataract when there is a good red reflex on coaxial illumination. The utility of this feature during a capsulorhexis is called as coaxial rhexis. In circumstances of poor red reflex on coaxial illumination as seen in total cataracts, the contrast can be enhanced by staining the anterior capsule with trypan blue dye. Trypan blue is injected under the air bubble in the anterior chamber for uniform staining of the anterior lens capsule and provides a color contrast during the capsulotomy known as blue rhexis. In certain situations, with availability of better operating microscopes, even the appreciation of the sheen reflex by slight manipulation of the globe, the course of the anterior capsulorhexis can be visualized and capsulotomy can be completed. And this is known as sheen rhexis. This technique can either be used independently or in combination with other techniques of capsulotomy. In the presence of anterior capsular plaque, such as in uveitic or a complicated cataract, the plaque can either be removed using a rhexis forceps known as plaque rhexis or can also be excised using a vitrector or a pair of micro scissors. In a case of a runaway rhexis, a vitrector comes to the rescue to round out the capsulorhexis. The Vitrector cut capsulectomy is a substitute to capsulorhexis performed by a rhexis forceps in situations such as crumpled anterior capsule in long-standing cataract, fibrotic anterior capsule, subluxated lens, traumatic cataract, and in membranous cataract. Capsulectomy using a vitrector is achieved by a high flow rate and a slow cut rate, and the cutting port faces the edge of the capsule and is enlarged in a spiral manner. This is called as Vitrectorhexis. Precision pulse capsulotomy, which consistently produces a circular, accurate, strong and well-centered capsulotomy, is a new innovative technology developed by Synopsis. The probe is collapsed and inserted into the anterior chamber, which is then reopened, centered, and suction is applied. A series of nanoelectrical pulse waveforms are applied through the nitinol ring, resulting in vaporization of water molecules trapped between the ring and the lens capsule, thereby causing an instantaneous 360-degree mechanical cleavage of the stretched capsule. This technique can be used as an alternative to manual capsulotomy in children and has the added advantage of resulting in a capsulorhexis which is round, well-centered, strong, and also has an easier learning curve. Although not frequently used in pediatric cataract, femtosecond laser-assisted anterior capsulotomy is another option which provides precise, accurate, and strong capsulotomy. A separate laser platform may not be feasible in children as pediatric cataract surgery is done under general anesthesia. Thus, anterior capsulotomy is dependent on the type and density of the cataract, the morphology of the anterior lens capsule, and associated anterior segment pathologies. This video highlights the 10 different techniques which can be used based on a case scenario, namely the gold standard manual capsulotomy aided by rhexis forceps or by using a vitrector with the assistance from the capsular staining or a coaxial illumination or by just the sheen of the capsule. The anterior chamber can be maintained using ophthalmic viscoelastic device or by an irrigation fluid. In the presence of a plaque, can be managed by rhexis forceps or by a vitrector or a pair of micro scissors. The technology of femtosecond laser-assisted capsulotomy and zeptopulse precision capsulotomy are also illustrated. Thank you.